Dear all, it's already the hour, and we're pleased to start with the third NEMUS webinar. NEMUS is the network for the multidisciplinary study of ARV-based HIV prevention, and this webinar is focused on the title of the session is Getting Past Go, Taking PrEP from Clinical Practice to Public Health Benefit. We're pleased to have with us Dr. Dawn Smith. Before she starts, actually, while we wait perhaps for a couple more people to arrive, I would like to make some announcements. First, we are trying to schedule monthly webinars in English. These webinars are focused on a number of topics that are of relevance to NEMUS and to NEMUS participants. Probably this is our second webinar in English, and we're planning our next one by the end of July, probably after the Melbourne conference. We hope it's going to be focused on issues that emerged at the Melbourne conference that may be of interest to us. Probably that will be scheduled the 30th of July. Second, we are trying to keep with bi-monthly webinars in other languages. We started earlier this month with a webinar in Spanish. We're planning upcoming webinars in Portuguese and French. So probably in early August we'll be pleased to offer a webinar in French. Those tend to be more general in scope. Third, we are happy to announce that we have finalized the planning of a session at the Melbourne conference, International AIDS Conference. It's a satellite on Wednesday, the 23rd of July at 6:30 p.m. for those who will be there. And it's focused on PrEP as part of combination HIV prevention, using evidence and identifying research gaps. Guest speakers there will be Rachel Bagley from WHO, and Ken Meyer, Judy Auerbach, Jim Rooney, Fabio Mesquita, and doctors Hannah Ngure and Murphy. So we hope you can be there. Otherwise, we'll present a report of that meeting. Then we'll all of you actually will be on mute, except Dawn and myself. However, please use the chat window to start making questions whenever you like, and at the end of Dawn's presentation, we'll summarize the questions and start a discussion in that way. We do that to actually avoid interference that sometimes happens if we have too many people speaking. So now I think it's time to let Dawn speak, and I'm really pleased to introduce Dr. Dawn Smith. She's the Biomedical Intervention Implementation Officer at the Epidemiological Branch, DHAP, NCHHSTP at the U.S. Centers for Disease Control. She has been directly involved in the launching of the CDC PrEP guidelines in the U.S. And we thought that the ideas she has and probably results of implementation of those guidelines so far may be very interesting for an international audience. So again, I'm pleased to leave Dr. Dawn Smith with you. Please, Dawn, thank you for being here.
Hello, everybody. Thank you for the invitation. The term "getting past go" in this presentation refers to a kind of sports analogy where when racers are getting ready to start a race, they say ready, set, and then go. So for us, we think of ready as the clinical trial results showing efficacy of PrEP. Getting set was the FDA decision that Truvada could be prescribed for PrEP in the United States. And the go signal was the issuance of formal public health service guidelines for the use of PrEP in the United States. So we're now turning our attention to how we actually take PrEP into clinical practice and beyond that to achieve public health benefit. So the issues that we're going to talk a little bit about that came up before we issued the guidelines, and then we'll talk a little bit about what we've learned in the interim about these issues, is what is the evidence supporting the use of PrEP? What are the epidemic realities in the U.S. that indicate a need for an intervention like PrEP? What were the things that supported the idea of implementing PrEP, and what were the concerns about the idea of adding PrEP as a component of HIV prevention in the United States? So early hopes for PrEP were that PrEP would help to reduce new HIV infections in the U.S., and that because it requires HIV testing, this would be a reason for more people to get tested. Not just to find out if they were positive so they could start treatment, but to confirm that they were negative so that they could consider all their options for preventing HIV infection. We hoped that it would help with HIV prevention for people who had multiple risks. So whether you had a bisexual man who has sex with both men and women, or a sexually active person who also is injecting drugs, our hope was that PrEP would be effective for multiple routes of transmission and could be used to prevent HIV infection in those people who had multiple risks. We thought it would be useful because it offers an option that's under the control of the receptive sexual partner, and it may offer an accessible, safer conception option for negative partners in HIV discordant couples who want to get pregnant. And lastly, in the United States, we have problems with access to routine health care and sexual health care for underserved populations. And we hoped that PrEP would provide a motivation for uninfected persons to access primary and sexual health care services. So what was the evidence that made us enthusiastic about the possibility of PrEP? Well, there were a couple things. One is when we first started using zidovudine to reduce perinatal transmission, there was a study that looked at what the perinatal transmission rate was depending on when the zidovudine was started in relation to the birth. And so the lowest transmission rate were women who started their zidovudine during the prenatal period and continued it through delivery. But there was also significant effectiveness in women who started it right at the time that they were in delivery or within a couple days after delivery. And then there was less effectiveness if it was started in the month after delivery. And so all of that made us think that the use of antiretrovirals before exposure to HIV, in this case for infants, would be a highly effective way to try to block HIV acquisition. There was also an early PrEP trial that was stopped before completion, but had enough observations to give a hint that we might have efficacy. This was a trial that used tenofovir alone daily, and there were lower rates of infections among those who took tenofovir than those who took placebo, although it didn't reach statistical significance because of the early stoppage of the study. So the preliminary concerns about PrEP were that it would displace condom use, that people would abandon condoms, that it would lead to reckless sexual behavior, having sex with multiple partners without condoms, that this would also increase rates of sexually transmitted infections, that it might increase drug-resistant virus in the community, it might cause renal failure or poor bone health in healthy people. Among the people who were less concerned about safety, given its strong safety record in people who use it for treatment, there were still concerns that it would be unaffordable either for individuals who were trying to access it or for the healthcare system in terms of providing it. And similarly, there was a concern that any funding that was provided to start up PrEP would reduce the available funding for HIV treatment. None of these has turned out in early days to be a significant concern about PrEP, but these were the things that people were worried about in the early days. So then we got trial results, and that gave us some real evidence about how well PrEP does work for different routes of transmission, with different levels of medication adherence, and with what balance of benefit to harm. So what we were able to show from the trials was that PrEP can be very effective in men who engage in rectal sex with men, in men and women who engage in penile-vaginal sex, either in a discordant couple or outside of a discordant couple, and for men and women who inject illicit drugs. When we look at the trial results, the efficacy that was demonstrated plotted against the percentage of participants who had detectable drug levels as a measure of adherence to their medication. What we found was that PrEP can be highly effective if the drug is taken as prescribed daily. So to the far right and the top, where you have high adherence, you also have high effectiveness. In the IPREX trial, the TDF2 trial, the Partners PrEP trial, where drug levels were measured. At the lower left, you have trials where you did not see significant efficacy, and those were also the trials in which there were low rates of detection of drug in the participants' blood, indicating that few of them were taking the drugs as prescribed. This is another way of looking at the same data. In the IPREX trial, if you look at the average efficacy comparing everyone who was randomized to drug versus everyone who was randomized to placebo, not accounting for whether they were actually taking the drug, there was a 44% reduction in the risk of acquiring HIV infection among those who took the Truvada. However, if you looked among those who had drug detected in their blood, there was a 92% effectiveness. And similar results were found for Partners PrEP with heterosexual couples and for injection drug users in the Bangkok tenofovir trial, which used TDF alone, tenofovir alone. So to the issue of whether there were serious clinical risks associated with HIV uninfected people taking the drug, the trials have not seen any serious health risks. So on the left, there was an issue about renal risk, whether this would be associated with significant decline in renal function. In the Bangkok tenofovir trial, some patients were on study drug for as long as 5 years. And what you see when they looked at their renal function over time was that there was a small but clinically insignificant decline in renal function among those who were on the tenofovir. The red line indicates the level of renal function below which tenofovir regimens would not be used. On the right, in the studies that looked at changes in bone mineral density, the hardness of bones, and whether that was related to taking tenofovir. In the green lines, you see the results for people who were uninfected and who were taking tenofovir-containing regimen for PrEP. And the blue lines are people who were HIV positive and were taking tenofovir regimens for treatment. And what you can see is that for PrEP, there were small declines in renal function in bone density compared to that's seen in HIV positive people. And that it stabilized over time and didn't decrease significantly over the last 1 to 2 years on the drug. Similarly, when we looked at evidence of behavioral risk, In the IPREC study looking at sexual risk among men who had sex with men, in both the placebo and the tenofovir-containing arm. Now recognize that people didn't know which drug they were on during this trial. The number of receptive anal sex partners declined for both groups, and the percent of receptive anal acts that were protected with condom use increased for both groups. Similarly, in the Bangkok study looking at injection risk over time, the number of people who injected drugs in the months previous to enrollment was fairly high by intention. That was a recruitment criteria. But that number fell and remained low throughout the long duration of this trial, up to 72 months. Those who injected daily showed a small but not marked reduction. However, the proportion who reported sharing needles declined significantly and stayed low throughout the remainder of the trial. The one place where we do have some evidence of behavioral risk increase is in HIV discordant couples. If you look on the left, it's looking at rates of sexual behavior of the negative partner reporting their behavior with the positive partner. And this was done the trial was stopped early because of efficacy, and participants in the trial were told that efficacy had been found. So that's what the unblinding is. That's the point at which everyone became aware that if you take Truvada, that it would offer some protection. What you see is that with their HIV positive partner, the average frequency of unprotected sex on the top line really stayed consistent throughout the trial. There was a small increase after they learned the efficacy of PrEP. Where they did see an increase was sex with an outside partner. So among those who reported having a partner other than their HIV-positive spouse, you can see up until they learned the efficacy of PrEP, there was a very stable rate of both sexual activity and sexual activity without condoms. But as soon as they learned that PrEP was, in fact, protective, you can see that they began to have more sex and more unprotected sex with their outside partners. To the issue of why we think we need PrEP in the United States. In the early days of the epidemic, we had very large increases in the numbers of people who newly acquired HIV infection. But that with counseling and testing and public education and awareness and increased condom use, that rate fell pretty rapidly. However, during the most recent 15 years or so, there has not been a significant decrease in the number of people who acquire HIV infection every year. And that makes us think that in addition to the tools that we already had, that we needed new tools to help bring the epidemic down further in the United States. Now, these are the overall numbers. Within that, there are, of course, microepidemics. There are differences in several factors such that HIV new infections are concentrated in some populations. So in the United States, about 2/3 of new HIV infections occur in men who have sex with men. But even among men who have sex with men, if you look at the chart on the left, the number of diagnoses among African Americans is higher than that among whites and Hispanics. This is important because African Americans constitute only about 12% of the U.S. population. Hispanics are about 13% of the population, and yet they are disparately impacted by the number of new HIV infections. Similarly, if you look at the role that STIs play as a harbinger of risk of HIV acquisition, you see not only racial and ethnic disparities, but the impact of rectal gonorrhea and chlamydia on HIV infection rates. So among all MSM who were seen in an STD clinic, the annual incidence of HIV infection was almost 11% for those who were African American, 4% for those who were Hispanic, and 2% for those who were white. However, among those who had an episode of rectal GC or chlamydia in the observation interval, the rates of infection were higher for all three of those groups. This is an important tool for discordant couples to have at their disposal. First of all, among men in the U.S., a third of HIV transmissions are from the non-main partner. So if you're in a discordant couple with a positive partner and that partner is virally suppressed, a third of those men are also having sex with people outside of their partnership. And so there may be a role for PrEP to protect them during outside sex. And as you can see, the majority of those casual partners are of unknown or positive HIV status. Similarly, in several of the studies that looked at discordant couples in developing countries, in the Partners in Prevention study, which was a study looking at acyclovir and HSV suppression in discordant couples, a quarter of the HIV transmissions were not linked to the HIV positive partner. And in HPTN-052 that showed the benefits of early treatment for prevention, 18% of the transmissions were not linked to the HIV positive partner. So the next thing I want to just cover briefly is how different countries and different epidemic settings have estimated the impact of PrEP on HIV incidence. So in the United States, there was a study that was looking at the cost effectiveness of PrEP for MSM in the U.S. And they looked both at what would happen if we delivered PrEP to the general population of MSM, and what would happen if we delivered it mostly to high-risk MSM. And high-risk MSM in this case were populations of MSM who had 5 or more partners in the most recent year, and were in a fairly high prevalence community. And what they were able to show is that, so if you look at the little color codes on the left, what you want to have is a cost effectiveness, an incremental cost effectiveness that's below $100,000. So that means the sort of medium aqua, light aqua, or white area. Now they estimated using the 44% effectiveness from the IPREX trial. And then they were looking at whether it was cost effective given different costs of a PrEP program. So the top is the estimate in the United States for the drug and the services. They estimated it would cost about $10,000 per year. And so for all high-risk MSM, in the base case of 44% effectiveness, it was cost-effective for high-risk MSM. And in fact, if PrEP were delivered to 20% of high-risk MSM, it would prevent 60,000 infections over the following 20 years, and that's of about 500,000 that would be expected. So about 13% of infections would be prevented by treating 20% of high-risk men. If you treated 100% of high-risk men, then the cost per infection inverted is very low. It's less than $50,000, and you would prevent 167,000 HIV infections, and prevalence among high-risk MSM would fall from 31% to 17%. This analysis looked at PrEP for HIV discordant couples in South Africa, where there is rapid scale-up going on of HIV treatment. And so they wanted to look at, in a couple, you would want to try to keep the couple alive, so the HIV positive partner alive and the HIV negative partner free of HIV infection by age 50. So that was the outcome that they were looking for. And they asked the question, what's the benefit of PrEP in relation to the use of antiretroviral treatment for the positive patient? And they looked both at PrEP effectiveness and the relative cost of PrEP to ART. So if you say that PrEP, for example, costs 80% of what it costs to deliver ART, and you follow that line across, what you can see is that it remains cost effective at all levels of PrEP effectiveness. This was done before any of the trial results came in, until starting a person on antiretroviral therapy. But if you're able to drop the cost of PrEP related to ART, let's say to 40%, then it becomes less cost effective, particularly if you're able to start ART at less than 500 instead of less than 350. This was a study that looked at infections averted with PrEP given to MSM in Peru, and it looked at different groups of men who have sex with men. So of those who had sex with women, as well as men, it would have less of an impact on incidence than among those who have sex with men only, and those who were sex workers, and the highest risk group, trans women. So it's possible to use these kinds of impact analyses to look not just at cost or comparative cost to other interventions, but to look at the impact within populations. In a similar way, this study looked at PrEP for injection drug users in the Ukraine and looked at it with and without methadone maintenance for drug users, and with and without PrEP for either 25% or 50% of injection drug users. Looked at the effect that PrEP or any of these interventions alone or in combination would have on both the number of HIV infections averted among injection drug users and among non-injection drug users, i.e. their partners. And so what you can see here is that it's kind of intuitive, but that at every stage, if you add PrEP, you get more infections averted. And that if you use it in 50% or more, you get particularly high levels. But also that if you use all three of these methods, so if you scale up antiretroviral treatment, you scale up methadone maintenance for drug users, and you provide PrEP, you avert the most infections. So the other issue was cost. So I need to tell, for those in the international audience who don't have a lot of experience with our health system, I need to give you a little brief explanation of how things work here, because it's different than in most other countries. We have an entirely what we call fee-for-service system, which means somebody has to pay for every service, but that's not paid for across the board, for example, by a national health service or a federal government. So how to cover the cost for healthcare service varies by a lot of different variables. We have public insurance, we have private insurance, we have self-pay, and all of those things are determined by eligibility criteria. So some things are for people who are poor, some things are for people of a specific age or who have a particular illness. We have special services that provide essentially free health care to people in military service, to the indigenous populations in the United States, which is a service called the Indian Health Service, to students in school. And then we have a lot of things where services are paid for by insurance that either you buy or that someone buys for you. And those tend to cover both procedures, in some cases preventive care, and usually medications. Now, for people with insurance, we also have, the insurance often doesn't cover the whole cost. So we have some systems where you have to pay a small amount. Let's say for each prescription you might have to pay $10. We also have a system for other costs where you pay a percentage of the cost out of your own pocket. So you might have insurance that covers 80% of when you're in the hospital, but the 20% you have to come up with on your own. So if we look at how this works in the US, for example, and how it might affect PrEP, so about 50% of young people, 19 to 25, have private insurance. About 13% have public insurance, and about a quarter have no insurance and would have to pay for all PrEP costs out of pocket. That's important because that's the age group in which HIV infection is rising fastest in the United States. You can see that for those adults, so 18 to 64, there's a similar pattern, but there's somewhat a little bit less of the uninsured. So in trying to figure out how to cover PrEP costs in the United States, about 85% of the cost of care is the medication. And most public and private insurers in the United States have agreed to cover PrEP as a service. And we have a new system in the United States that is trying to increase access to health insurance for those who don't have it. However, at the same time, this doesn't really help with the situation where there's co-insurance for medication, where you have to pay a proportion of the medication cost out of pocket. Because Truvada is an expensive drug, that can be a very high cost when you have co-insurance. So for those people who have low income and no insurance coverage, the drug manufacturer has made available a medication assistance program that will provide free drug to the doctor to give to the patient, and provides a small level of assistance with copays. In addition, we have one state in the United States that has decided to set up its own drug assistance program. So we have ways to reduce the costs of PrEP services for many patients in the U.S., but not all. So the next thing that we are focusing our attention on in the United States, now that we have our regulatory approval to use the drug, we have systems in place to try to pay for the drug, we have guidelines for how to use the drug. Now we need to get some evidence about how is it actually going to work when people try to use it in practice. So an early study was initiated to try to evaluate whether people wanted PrEP at the rate that we think it would be needed, and whether they would take the medication as prescribed, because as we showed from the earlier slide, if you don't take the drug, it doesn't have the desired effect. So they recruited men who have sex with men in sexually transmitted disease clinics, and about 60% of those who met the criteria for PrEP were interested and decided to take PrEP. So they looked at medication adherence at 4 weeks on PrEP by checking blood drug levels. And what they found was that daily adherence to the medication was not as high as we would have liked. So across all the sites, there were 3 sites, Miami, Washington, D.C., and San Francisco. And across all the sites, only about 1/3 of the men had levels of drug in their blood that are associated with taking 7 doses per week. However, that's not as scary as it seems, because 3/4 of them had levels of drug in their blood that was associated with taking 4 or more doses per week. And in another study, 4 or more doses per week was associated with greater than 90% effectiveness in HIV prevention. So if you're taking your drug regularly and you miss an occasional dose, there is still a fair amount of protection offered. As we turn to look for more practice-based evidence, we have to decide what things we want to actually look for. So one of the things, if we're trying to get impact on the national rates of HIV incidence, we need to look at the reach of PrEP. So what proportion of the target population is getting PrEP, and are these the people with the highest incidence? So if we end up having very high coverage among people who are at very low risk for HIV infection, we won't have much of an impact. We need to look at whether we see changes in HIV incidence or newly diagnosed HIV infection. And we also need to understand if there are any adverse outcomes from PrEP use that we weren't expecting. We need to look at how available PrEP is, and then when it's available, how many people and which people are accessing PrEP. We need to look at whether PrEP is being delivered according to the guidelines or whether there are significant variations. So for example, if people decide to prescribe PrEP without first testing to ensure that patients are HIV negative, we could do more harm than good. And lastly, we need to follow patients over time, both to understand what the impact of PrEP use long-term is on patients, to understand how long people want to stay on PrEP, and when and why they want to change to another form of HIV prevention, but also to understand from a clinician or clinic setting, what's the sustainability of the PrEP program. Right now, when we introduce a new clinical intervention or any other kind of intervention, there's something called the diffusion of innovation. So it doesn't spread instantaneously. There is a kind of a gradual increase in the number of people who are trying it, usually by people who like to try new things or people who like to be on the forefront. And then as they get some experience, you get to the place where all the people around them who are watching and say, oh, that looks like I could do that. It looks like it's a good thing. Begin to adopt the new practice. And then later you get people who are like, well, everybody I know is doing this, so I better go ahead and do it. And lastly, you get the people who really are reluctant to change, but do eventually do that. And we seem to be sort of in the middle of what they call the sort of tipping point, where the early opinion leaders and experimenters have already tried it and are beginning to report out their results, what problems they had or didn't have. And some of the other providers in the community are saying, oh, I have patients who would be good for this. I need to know how to do this. It's important, however, not to get ahead of ourselves. I think in HIV we're very used to the idea that things will be taken up extremely rapidly. And I think that isn't the case for most new medical interventions. It's estimated that on average it takes 17 years from the time a trial shows efficacy until a new medical intervention becomes standard of care. And this gives you an example of the range of adoption rates that have been seen with some very common practices in the United States. So judged against this usual practice, we're actually doing pretty well. People are always saying that PrEP uptake is very, very slow, and I think it is at or above what would be expected for a new medical intervention. So Gilead Sciences did a recent analysis where they looked at all of the commercial pharmacies that report to a big database that has about 55, a little more than half of all the pharmacy prescriptions in the country. Notice that this does not include people who are getting their PrEP through participating in a study or being in a clinic setting where the clinic itself dispenses the medication without a prescription to the pharmacy. And what they found at the end of 2012 was that there were people prescribing PrEP in about 700 cities in the U.S., all but one state in the U.S. Most of the prescribing was going on by general practitioners, either family medicine or internal medicine doctors. About a third of the people who were prescribing PrEP were also treating people with HIV infection with Truvada. And their prescriptions were increasing. So in 2011, the first year after the IPREX trial results had been released, there were 150 prescriptions that they found. In 2012, that had gone up to 1274, which is about an 8.5-fold increase. A few of those were for persons under the age of 25. As I told you, 18 to 24-year-olds are the most rapidly growing part of our epidemic, and about a little under half were for women. Women account for about 20% of our new HIV infections. So the key implementation challenges that we have in the United States right now have to do with managing change and uncertainty. Until we have more experience with PrEP, how to provide it, what the long-term effects of it are, there's going to be a fair amount of uncertainty and a lot of questions. And even so, we need to begin using it. We need to increase the number and the availability of knowledgeable PrEP providers. And so we're putting in place systems to identify and train primary care and STD providers, but also to identify HIV care providers who will either provide PrEP or service training and referral sources for the primary care docs who may have less experience with antiretroviral medications. In the United States, we have a system of care for HIV providers where we have a federally sponsored system that can only provide care to HIV positive people. So many of our care providers work in that system and they can't see HIV negative people with that funding. But then we have a lot of providers who are in private practice who can see pretty much any kind of patient they want to. We need to increase the awareness of PrEP. One of the big problems we have in the United States is that most of the people in the groups with the highest incidence have never heard of PrEP. So they're not asking for it, they're not going to their physicians and discussing it with their physicians. And that's even true among HIV negative persons who have HIV positive partners. We need to develop better ways to measure the impact of PrEP, either positive or negative, at the population level. We have good methods to look at the medical records and see what happened to a given patient, but at the moment we don't have a way to say, oh, HIV incidence is going down in this place because X% of people started PrEP, or we were scaling up treatment and we were scaling up PrEP and we saw some changes in HIV incidence, but how do we attribute them to one or the other or both? We need to coordinate better the clinical, behavioral, and social service interventions we have available related to HIV prevention, and be sure that clinical providers have access to all of these kinds of services by referrals or within their systems so that patients can benefit from the synergies from these different kinds of interventions. And we need to coordinate financial assistance with the medication, but also with the clinical, laboratory, and counseling costs associated with PrEP. If we can do all that, I think we are in a position to use antiretrovirals for HIV prevention to effectively wind down new HIV infections in the U.S. And it all starts with getting more people to know their current HIV status. If they're HIV positive, putting them on antiretroviral medication for their own treatment. If they're pregnant, putting them on antiretrovirals to prevent transmission to the baby will be a big part of reducing new infections. If they're negative, offering them pre-exposure prophylaxis if they are at very high risk, offering them, making sure they're aware of post-exposure prophylaxis if they don't have ongoing risk but may occasionally have a risk event, will help us to decrease the susceptibility of high-risk HIV negatives to HIV infection. For all of these interventions, it will be important to have support systems in place so that patients can adhere to their medication and their care visits, as well as manage their behavioral risks, whether they're sexual or injection. Particularly for HIV positive patients, it'll be important to help them work with them to disclose their HIV status and their treatment status to partners, so partners can make appropriate decisions about sexual behaviors and the use of PrEP or NPEP. For HIV negative partners, one of the problems we have in the US is that often people don't disclose to their provider what sexual or injection risks they may have. And we need to make sure that providers ask better questions and ask them in a better way. But we also need to encourage HIV negative persons to be more forthcoming with their providers so that appropriate prevention options can be identified for them. Even though we've had this long history of it taking forever for things to get into clinical practice, I think for HIV in particular, we've had some spectacular rapid successes. This is an example from the introduction of highly active antiretroviral combination therapy, in which it was introduced in 1995. And as you can see, there was an almost immediate decline in death rates as the rates increased over a fairly short period of time in provision of heart. This is the other example, which is perinatal prophylaxis. In 1994, the trial result was released showing that perinatal zidovudine reduced HIV transmission to infants. And as you can see, we had an almost immediate and sustained decline in perinatal transmissions as we learned to identify HIV-infected women early enough to provide this important prevention tool. So that's where we are in the United States, and I'd be happy to have any questions.
Dawn, thanks very much for an extremely interesting presentation about the experience of the U.S. having decided to undertake PrEP implementation officially. And while we wait for people to perhaps submit their questions through the chat window, I do have some questions I would like to start with. And to me, probably, and this is related to the way the U.S. health system is organized. Maybe, probably in many other places, there's a logic of public health programs that are funded either by the government themselves or by international funders, and that's different from perhaps individual prescriptions that physicians can make to specific people. So probably in many cases, for example, in Latin America, I would envision that might happen, that PrEP might eventually become available both as an individual choice or prescription by a physician, or as a public health program that is funded by the government and that targets a small percentage of the population that is at very high risk. So in certain countries, potentially, this might be undertaken, or programs that include PrEP within the combination prevention framework might be started to be funded by the Global Fund or even PEPFAR. How do you see that picture?
I think that in a system where when the government approves something, it then begins to pay for it directly. The issues of targeting and cost effectiveness become even more critical than in the United States. So I think the kind of analyses that will need to be provided to the government to justify expenditures on something expensive like PrEP have not just to do with the efficacy of it, but have to do with can you identify a population that has high enough incidence and is going to adhere to the medication in a way that it makes sense to invest limited dollars in providing that coverage. So it can be specifically complicated because if you're in a country, for example, where it's dangerous or highly stigmatized to admit to a certain behavior, commercial sex work or being an MSM, and yet those are the populations with the highest risk of HIV infection and therefore would stand to benefit from PrEP, it's going to be very difficult to try to implement it. On the other hand, I think there are some situations where there is broader support for PrEP. And so the kind of analysis that South Africa did, where they were saying not just PrEP instead of TASP, but looking at discordant couples, which everyone is concerned about, and saying, when does PrEP make sense? So you could make a case that PrEP makes sense until the positive partner is on treatment and virally suppressed. That may be an easier place to start in countries where there's a lot of controversy about high-risk populations.
Mm-hmm. That's well, I think that's exactly the kind of contribution that this network tries to make. I mean, to probably introduce tools that can help countries better decide how, to what extent, for whom PrEP might fit within a combination prevention framework for different populations. Now, another question that would be interesting, at least to me, is the issue that at least in the U.S., the message of dual protection hasn't been clearly addressed, and probably many people feel that perhaps the real added value of PrEP for many would be that they would feel they don't need to use condoms, or probably people are already not using condoms, and some of them might be very good PrEP users. So to what extent the political difficulty of others in this is perhaps being an impediment for a more clear targeting of PrEP to the people who would best benefit from it?
Yeah, I think that has been a problem, and I think it is in many ways a circular argument that we need to find a way out of. So there's two things. First of all, condoms, as self-reported condom use, we have no hard marker for condom use, really. Self-reported condom use is somewhere between 70 and 80% effective. And so one of the messages that we encourage is, if you want to use PrEP, PrEP is not 100%, condoms are not 100%, but both together are even more protective. And so to try to reinforce for people that if you are a person who can't consistently use condoms, you may be appropriate to start to use PrEP, but you need to use PrEP with high adherence for its efficacy. And so, again, using both together may be the best strategy to keep you HIV free. So we're trying not to overpromise, not to give people the idea that, because PrEP can be highly effective, every other prevention method goes out the window, because that's clearly not the case. And the example that we typically use is from oral contraception. So we tell women, we have for 20 years or more, take oral contraception or take an injection, because these are highly effective ways to keep you from becoming pregnant. However, they don't protect you from STIs, and STIs cause their own morbidity and can impair your future fertility. Therefore, we say even if you're using a highly effective hormonal contraception, you should still continue to use condoms. Now, we know that many women who use highly effective contraception don't use condoms, but we don't tell them to do that, and we don't encourage them to do that. And I think we're in the same situation with PrEP. We can't require people to do anything. What we can do is give them the best information for how to protect themselves from HIV infection.
Mm-hmm. Exactly. There was one question asking that if uptake in the U.S. had been slow, how we would expect it could go up in other countries, in countries with lower resources. But actually, apparently that question has already been answered, as the person himself recognized that, because there's a social diffusion effect, and it may take some time. Then there's another question. People in high risk, at high risk, may be thinking this is a way to switch from condom use to PrEP use, no? And well, in a way, I think I don't know if you want to add something. I guess you have already responded that. It's a matter of what the message, the real message is, what is provided, and second, what the actual use and ability of people to use condoms is, and what the potential ability to be adherent to PrEP would be. But do you want to add something?
Yes.
Yeah. And actually, there was one thing that is very much related to it. First, I understand that there are evolving ways of looking at adherence to PrEP, because PrEP is not treatment, and it's not. The need for PrEP depends on risk, and people recognize that the risk may vary. That even people who are normally at high risk because of their sexual behaviors may change that, and they may be sick and know they won't have sex, or they may just be away from potential partners, and so adherence is probably not necessarily something that people will comply with as with the treatment, and that's not necessarily measured in studies. No? So what do you think about how we could improve our measurement of PrEP, and even perhaps fine-tune the advice related to PrEP, saying that, well, if you stopped taking it for X number of days, so definitely you're not protected with PrEP, and you would definitely need to use a condom. Even if you are protected, you should use a condom, but especially if you are not taking PrEP in the last few days, you definitely need a condom, something like that. What do you think?
I think you raise a couple of questions. One is, sometimes they talk about it as the difference between adherence and persistence, but I think there's a similar issue again with oral contraceptives. So what we tell patients who are taking oral contraceptives is if you miss more than 2 doses, then you should not consider yourself protected for the rest of that month, and you should be sure that you use condoms if you don't want to get pregnant. And so I think there is a role for saying something similar to a person who's taking PrEP and, you know, they have an unexpected trip, they forgot to take their medicine with them, now they've been off their medicine for 3 or 4 days. I think we should say to them, look, you know, you've had a lot of time for drug to leach out of your cells, and you probably should be using condoms if you're having sex during this period until you've been back on the drug regularly for a week or so. That's different than the question about if my partner's going away. And again, it's the same thing. You know, if I'm married and my partner is shipping off to fight in the Army and he's going to be gone for a year, if I know that he's my only partner, then if I want to stop birth control pills until the month before he comes back, that makes perfect sense, and nobody would disagree with that. And I think the same thing could be true for PrEP. If I have an HIV positive partner and I'm on PrEP because I'm concerned about my partner's viral load not being fully suppressed or whatever, and now it's a year later and my partner's been virally suppressed for 6 months and he's taking his meds regularly, and I may feel like I don't need PrEP anymore. And that makes perfect sense. But then my partner and I break up 2 years from now and I'm out having, you know, making friends with people, and I think maybe PrEP would be a good idea for me again, then I would start it again. But while you're taking it, you would take it every day.
Okay, well, great. Thank you very much. We are at the hour now, and I would just first reiterate that our next webinar is probably going to be scheduled for the 30th of July with news from Melbourne. Second, that we will have a session in Melbourne on the 23rd of July at 6:30 p.m. and we'll be sending a separate announcement. Third, that this session has been recorded, as all our webinars will be, and this will be distributed via email and posted on our website. And finally, to thank you again, Dawn. This has been extremely illustrative, really very useful, and I'm sure for people who participated and for people who might access this material later, this will be helpful in their work. Thanks again, and we'll see you all soon.
Bye.
Okay. Thank you, Dawn. Bye. Thanks.